Hi, everybody. Bryce Paschold, a podiatrist in Central Illinois, Bloomington, Illinois, the team podiatrist for Illinois State and Illinois Wesleyan athletics. Also, quite a few of the local high schools in town and everything. So just wanted to kind of, bring a little, my knowledge from a sports medicine standpoint to you guys. And I think most of you guys are first and second years. Is that right?
I think there's a good mix here.
Good mix. Okay. So hopefully it kind of, outlines, more of kind of the key points and generics, of just sports, being a sports medicine podiatrist and, but also going through a few cases and getting into a few specifics as well. So objectives of this lecture, what is sports medicine, from a pure definition standpoint, but also kind of what I, first perceive it as, injury prevention. Really that's a key, obviously, for all the athletes. We really want to try to prevent them from coming to see us. If we can do that, then that's obviously better than being reactive and only seeing them, when they have injuries. And then getting into the, specific injuries, acute versus chronic or overuse, the treatment for these injuries, and then a very important one, which is when to return to play. And that's really a big deal for any athlete. That's really how you'll be graded, I would say, even if it, whether it be fair or not. Their big thing is, they expect you to get them better, but it's how quick can you get them better, and they want to be quicker than anybody else. They want to return to, the field or the court, before, they should, whether it's reasonable expectations or really not. So what is sports medicine? The pure definition is an area of medicine that's concerned with treating specific injuries resulting from competing in, athletic activities. In my opinion, the treatment, the diagnoses, nothing is really different than, your normal, workup, your normal patient, your unathletic, patient. It's really, the difference is the demand, the time that they demand, the aggressive prognosis and aggressive treatment that you really have to, go through. That's going to be the big difference. Again, it's still medicine, it's still the same thing as any other patient. It's just the difference is they're going to expect more out of you. You're going to have to think outside the box. You're going to have to be a lot more aggressive. So, so sports medicine physician, our job really is to get an athlete back to play as quickly as possible and as safely as possible. This is the kind of the way that I see it. First off, we have to get them back safely. And again, sometimes that's later than the athlete expects us, to get them back. But that's our first job. If we can get somebody back safely and return them quickly, obviously that's kind of the end goal. And there, as you kind of go on, you'll find out that there are certain injuries or certain, patients that will see you that you can certainly kind of accelerate things, or get them back a little bit quicker, or kind of be, a little more aggressive with this. A good example is, an ankle sprain versus, say, like a stress fracture. An ankle sprain, there's a lot of times where, an athlete is getting back on the field before they're necessarily, 100%, ready to go or healthy. They may be, 80%, but that's good enough for them. They can pass, the rehab protocols. They can get back out there, but they just, there's always a risk, obviously, for, re-injury and things, and you have to talk about that. But, you can be a lot more aggressive with something like that versus a more high risk, stress fracture per se. So expectations. This is really, again, one of the main differences between, sports medicine and just regular medicine. This is something, it's not for the faint of heart. I would say this is time consuming, it's difficult work. A lot of times it's kind of it can be a thankless job because again, if you're not getting somebody, out there as quickly as they think you should, you're failing them. There's got to be a really good relationship between the athlete, the physician, yourself, the athletic trainers, coaches, parents. And if you treat any professional athletes, even agents. I mean, there's a big, kind of entourage around some of these athletes. So kind of the higher you go, with that, then the more you're going to see that. And obviously your weekend warrior athlete or, high school or junior high or something, you're not going to have that. It's more just going to be the coaches and the parents. But, you'll see this as you go up higher in level. Things to expect, expect second opinions, whether that be second opinions coming to you or, going away from you for a second opinion. Long phone calls. I can't tell you how many times that I've, talked to our athletic trainers after hours, or I get home after a day of surgery or clinic, and and they have questions or want to talk about the patient or bouncing things off of me. So you have to be willing to take those calls and answer all their questions and kind of expect that. And then one thing that's going to happen, you're going to get fired by a patient. And most of the time, you're doing everything right. And if you stick to your guns, you can sleep well at night knowing that, hey, we just didn't mesh, or, they didn't abide by, my expectations, or, weren't compliant with what I said. And sometimes, they'll try to push you into, certain directives of treatment, and that's not going to be best for them. And it's better for you to cut ties or to say, okay, you can, go somewhere else, so you don't back down from what you think is right. And then, not meeting athletes' expectations for return to play. I've kind of already talked a little bit about that, in terms of just, whether some athletes have realistic expectations, for when they can get back on the field or the court, or whatever their sport may be. Sometimes it's just, it's unrealistic. And obviously, again, you have to stick to your guns and know, when or when not they can, get back safely. But, with all these Debbie Downer things that I'm describing, it is extremely rewarding. It's very rewarding to get an athlete through an injury, and then to see him back on the field or back out there playing, and seen in the paper or on the news or what have you. It makes you feel good that you really helped him, and usually they are very appreciative, in most cases. So talking about injury prevention, kind of first off, how can we be proactive in this? Proper training is essential. Really, we want these athletes to be, on proper training protocols. They're not just going to be going from, it's not like a couch to 5K type, routine. And again, the higher level athletes, or the higher the level of the athlete you get, the more in tune they're going to be. You're not going to have to worry about that at all. You get to collegiate level, they're going to know what they need to do, and it's going to be almost a year-round thing. The dicier situations are when you have a high school or junior high athlete who, doesn't do anything other than just her season or his season, and they're trying to get back to things too quickly. And so that's when I kind of do counseling, on that regard. But again, even the high schools have athletic trainers, most of them do, and the coaches are pretty good with that, these days, in terms of getting them on a pretty good protocol in terms of, increasing things on a gradual basis, not just going out there and trying to, say a cross country athlete going to run, 10 miles the first time out, obviously they're going to have problems, and they're going to be overuse injuries if you do that. Proper footwear. So, shoes, orthotics, inserts, bracing, anything that, maybe needed from this standpoint. I can't tell you how many, times a day. I talk to people about supportive shoes and just, good shoes to invest in and to use. No different for athletes. There are a lot of athletes that I see that have gotten into trouble because of, the shoes that they're, wearing. Orthotics, inserts, again, that's something on an individual basis. Obviously, that's where, these kind of screenings come in. If you can get to these people early, before they either have problems or they may be seeing you for some other type of an issue, whether it be an ingrown toenail or a blister, or, something that's not, a musculoskeletal type problem. But you see that they have, a pretty severe flat foot, or, cable varus deformity or something. You may be able to help them, get them into these devices before they maybe would, and prevent injury. And bracing, a lot of times this has to do with, ankle sprains, previous ankle sprains, ankle taping, that type of thing, but ankle instability, those types of things. So just going again, kind of on a screening basis. And, sometimes, a patient will come in here for a certain reason, but you'll find something else, or try to, help them in some other way than maybe they knew that what they were getting into by, going into the appointment. Previous diagnoses and deformities. Again, this kind of plays into the, orthotics and bracing. Just if you've seen them before, for certain things, and they come back to you for something else, kind of knowing what they've already had, what they've dealt with, getting their medical history in terms of, previous injuries, previous foot problems, previous leg problems, previous, back problems. One big kinetic chain. Certainly there's a lot of times where we see, kids having, back problems or hip problems, because they have flat feet, or because they have a leg length discrepancy, things like that. It's really important to, kind of get a full, history, and, an overall medical history, and not just a foot history. Nutrition, supplementation, very important, especially for stress fractures. Proper nutrition, proper diet, certainly, but then supplementation is really important. Vitamin D, especially, as you see here in this picture, is important. It's always best to get vitamin D through the diet. The more vitamin D an athlete can get, the better it's going to be absorbed, and the better this is going to do for them. Calcium's a big player in this too. They work hand in hand. If you don't have calcium, you're not going to have the vitamin D that absorbs properly. So it's important for that. Any athlete that has a stress fracture, I will get a vitamin D, lab value on. And if some kids, refuse, or just are really afraid of needles, whatever it may be, if they refuse that, then I'll say, okay, you need to go on an over-the-counter vitamin D supplement on a daily basis. In my opinion, it's just so hard to get too much vitamin D, and especially with an athlete that, as much bony turnover as they have, there's just going to be such a risk of these stress injuries, if they're not at an adequate level. There's a lot more risk to me of having low vitamin D versus, high vitamin D. It's really tough to overdose on vitamin D. So, and if they do get a lab value and it's low, then I'll do a mega dose. And so we'll do like a weekly, 50,000 unit dose for like 6 weeks in a row, to try to get them, to boost them very quickly to get back up to an optimal level. But then even after that, I'll instruct them to take a vitamin D supplement on a daily basis. Calcium, I'm not as big on having them do the supplements, just because I think it is easier to get maybe too much calcium, starting getting, plaque buildup, within the arteries, that type of thing, it would be the worry there. So always try to kind of steer, them to get that through the diet. The foods that are high in this are always going to be vegetables, fish, dairy, the things you see over here. And then, just observing an athlete's gait and stance. And this is, again, a lot of these principles are just, general principles that will never, go wrong for you, when you get out into practice. But especially for athletes, it's really important to pretty much each athlete that you see that has either a foot pain or an overuse injury, something that they can, stand up. If it's like an ankle fracture, obviously they're not going to be able to just put a weight on it and stand up. But anytime they can, you want them to get up. You want them to stand up in your room. You want them to walk. You want to observe their gait, and their stance. I remember back in my training, somebody, an orthopedist that I was with, said, the worst enemy sometimes of podiatrists are podiatry chairs. And the reason he said that is because if you get somebody up in the chair and get them comfortable, it's just a lot less likely that you're going to get them down and get them to stand up. Obviously, you do procedures, you need them, to be elevated in a chair and everything. But I think it's just, it's a good habit to get into. Just any musculoskeletal type problem, you need to have them stand up, because you'll learn so much by just watching them stand and watching them walk. So getting back to the orthotics part of it, that there are certain, and I know you guys have been through this in school, but different types of orthotics, accommodative versus functional. Really, there's some good, resources out there for sports specific orthotics. I just kind of gave you a couple examples here. I mean, the one on the top left is really more of an accommodative orthotic with kind of like a nickel plast shell. That's better for like a court sport, basketball, volleyball, those types of things. Athletes seem to do better and tolerate better just with the amount of jumping and repetitive force, on this. Sometimes if they're in like a hard, rigid, functional orthotic, they just don't do quite as well, and it's just too hard for them to tolerate. The upper right, that's more of a dress orthotic, but you just wanted to give something that's a little bit thinner and narrower. A lot of times we'll make something similar for, like cleated sports, soccer, softball, baseball, football, things like that, that maybe just they can't fit, in the cleat as well with a full length orthotic or something with a post or anything like that. So, it's always better to give somebody something, and they fit in the shoes and they wear them versus, the optimal support, the most support that you can get, which would be great if you could, but if the athlete's not going to wear it, it's not going to do any good on their dresser. And then the one on the bottom, just a typical functional orthotic. And a lot of times, I mean, you see the posts, on here. A lot of times I won't necessarily post them. Unless they are in a sport that they can tolerate, that much, added lift to the heel. There's enough room in the shoe, and they have a deformity that really, warrants that. Because again, a lot of times they won't tolerate that and won't like it. So again, if we can just get them some arch support, sometimes some realignment at the same time, that can be great. And there's can be some accommodative, additions that we can make, great. But again, I find sometimes, if you do too much with athletes, they don't tolerate them and just won't wear them. And it's a lot of times you won't even know it because they won't tell you. You ask them if they've been wearing them and say no, they didn't fit. And so okay, thanks for telling me. Thanks for helping that. We could have helped it. So a lot of times it's kind of lesser, is more with athletes, which is obviously a lot different than sometimes what you will learn in your orthotics labs and biomechanical classes. Not saying it's the perfect thing from that standpoint, but in sports, sometimes you have to be more minimal. The certain sports, that you'll see, injuries in. I mean, again, this kind of depends on where you're at, what type of a clinic or what type of practice you have. Even geographical location, can play a role in this definitely. But these are kind of things, you'll see. I mean, some of these sports, you'll see, more specific injuries. Whether it be basketball with, more Achilles injuries, definitely, whether it's an acute rupture versus Achilles tendonitis, overuse injuries, stress fractures, definitely, see a lot of stress fractures in basketball. And a lot of times they're the worst ones. Most of my navicular stress fractures that I've dealt with have been from basketball players. Football, certainly more contact, more acute injuries. Probably the most Liz Frank, injuries, dislocations, fractures that you'll see out of any of these sports. Let's see, skiing, so again, just depending on where you're at, certainly, a lot of acute injuries. I mean, there's a lot of knee injuries in that, but from a foot standpoint, I mean, like cross country skiing, that's something, where, they're up on about 90 degrees on their big toes. And so you'll see a lot of, arthritic, or hallux rigidus, arthritis to the big toe joint, pathology within that area, that type of thing. Hiking, that's again another geographical one, but a lot of ankle injuries, fractures from falls or twists. You'll see on the uneven terrain, fifth metatarsal, fractures and injuries because they're on the uneven terrain. Cross country and track, that's a huge one. That's probably the most, most of the athletes that I see or the largest majority, just because of the overuse injury aspect of this. I mean, you're going to see the most stress fractures from this type of a sport. And dance, I mean, that's kind of an interesting one, just because they're, really doing so many things differently than these other sports. I mean, being on point, going up on their toes. I mean, it's just, you see a lot of, sometimes big toe, injuries and issues. I've seen some, ligament tears within the first metatarsal phalangeal joint, capsular tears, sesamoidal, ligament tears, because of that. But then also, a lot of Achilles issues too, because they're up on point and using that a lot more. So acute injuries, just kind of a list of them. This is not obviously, all entailing, but just some more common ones. Probably the most common one that you'll see from an acute injury standpoint is an ankle sprain. The statistics on this are, they're the most common musculoskeletal injury that comes into ERs, and, probably will be the same, if you're in a busy sports medicine clinic. So you have to, know how to take care of these, and you really should have a protocol for kind of each one of these. If it's your typical, ankle sprain or anything else like this. Obviously with practice routine, you'll get the hang of it and kind of go through, your protocol and kind of, get patients, steered in the right direction, and have confidence, in that protocol and in order to get them back. And ankle sprains too. I mean, that's a big one in terms of just expectations. I think, it's always important, any research or any data that's out there for return to play from these injuries is really important to an athlete. So the more you kind of know about that, because that's really what they care about, hey, okay, what's going on? Is it broken? Is it not broken? And then, what am I going to do? When can I return to play though? That's really what they want to hear. So if you have data, on this type of thing, that really helps from an expectation standpoint. So I always talk about, ankle sprains to athletes with, a mild, moderate, severe, type sprain, and try to kind of grade it. And therefore I can kind of give them a better, return to play prognosis, whether that be 0 to 2 weeks or, 4 to 6 or even above sometimes. So foot sprains, as well. A lot of times you'll see similar mechanism, cause maybe a bifurcate ligament sprain. These usually heal quicker than ankle sprains. So again, that's just something, to tell the athlete. Liz Frank sprain certainly is the big one with this. And that's something where you want to tell them that, hey, even though it's a sprain, this can still knock you out for a season. It can be a season ender for a true Liz Frank sprain. Contusions, that you'll see a lot of these. And, the nice thing sometimes is, you give people a good prognosis and say, hey, this hurts a lot right now. It's bruised, swollen right now, but, this should be okay in, a couple of weeks, not a month or two. And people like to hear that. Sometimes it still takes mobilization and rest, and they're still out for a little bit, but the prognosis is certainly better. Acute fractures, there's just too many of them to kind of list, but you need to know obviously which ones need surgery, which ones can be treated conservatively, in order to return, that player, back as soon as possible. Liz Frank, dislocation. This picture is showing that, shows the flex line. This is something that's very subtle, sometimes. This one's a pretty easy one to tell, that diastasis, that widening there. But there are a lot of others that, aren't that easy. And it's really important to always get a weight bearing, foot x-ray for these, and then also get a comparative view, to the other foot. There's so many times where people's anatomy is just kind of different. It's really tough to say, well, is this just a little wide or is this normal? And if you get the other foot, something to compare it to, so much easier. A lot of times, when they originally come in, they're swollen, they're painful. Everything hurts. They can't put any weight on it. So you're not going to be able to get a true weight bearing x-ray at that visit. So what we'll do if we're worried about it and we can't tell, on the x-ray they got, then, we'll try to compress them, splint them, stay off their feet, do all those things for swelling over the course of a week or so, and then have them come back in a week. And a lot of times their pain's a lot better, so then they can tolerate, weight bearing x-ray at that point. Toenail injuries, you'll see this, a lot of times, runners, will get these, subungual hematomas. We call them runner's toe. A lot of times with the second digit, just because it hits the shoe, a lot more frequently. Just need to know how to treat those. And a lot of times it's just relieving the pressure and draining it or opening it up, will help them immensely. Skin injuries, blisters, infections. I mean, that stuff's going to happen. Getting back to the orthotic thing, one thing that I would always kind of advise you is just, the orthotics can cause blisters. And if you're not careful, that can knock an athlete out for, a week or two. And that anytime, an athlete has blisters and it's something that you really did and, truly caused it, it doesn't look good for anybody. So I've had that happen a couple of times. And it happens once, you just never want it to happen again because it's something that, could have prevented. Just really important, with orthotics to, have the athlete break them in slowly, first just in normal shoes. But then after they're broken into normal shoes, then you break them in their cleats or their sport specific shoe. And it's really nice to have an athletic trainer that can help you do that. So they can, they're only doing it for 20 minutes, 15, 20 minutes the first time, then take them out, put their other stuff back in. Next practice, a little bit more and just, really increase slowly from there. And that really decreases the chance of blisters happening. Compartment syndrome, I mean, that can, definitely happen in athletes. I mean, I remember, a baseball player actually had this and it was just really strange, just like an ankle sprain. And, it didn't show up immediately. A couple of weeks later, he had these complaints and, just kind of a weird thing. You think of more of a crush injury or a car accident or, these high energy, mechanisms causing this. But I mean, if there's enough swelling, from a sports injury, I mean, it can certainly, happen as well. So just keep in the back of your mind, it's not going to be a common thing, but always want to be prepared for that. And then Achilles tendon injuries, especially ruptures. This is a pretty easy one to diagnose. You're going to know, right away with this, and just be prepared to tell an athlete how long they're going to be out for. This is kind of one of the longer ones. I'd say Liz Franks and Achilles tendons. Those are going to take the longest. So just be prepared to give them kind of bad news and in their season. So overuse injuries. Number one, is always going to be stress fractures. This is a picture of a stress fracture. With the swelling involved, you can see the difference between the right and left foot. Not all stress fractures are. I always say stress injuries, just because I kind of group stress reactions, into that category as well. Stress reactions are really a precursor to a stress fracture. It's treated the same. It's just a better prognosis. It's just less time, in a boot or rest or off their feet. But that's kind of a better way, I think, to tell patients, like, hey, without getting an MRI, a lot of times we're not going to see anything on the X-ray from a stress fracture standpoint, at least at first. But this is what we're treating, and usually you can, kind of play it by ear and just see how they're doing clinically before rushing to an MRI on every patient. Now, with athletes, you're always going to be doing things like MRIs quicker. Because they're going to be more, again, demanding. The coach is going to want to know exactly the time frame. They're going to know exactly when they can play again. And if you tell them a range of, 2 to 6 weeks, they're going to want something, more hard, fast. So a lot of times we do get MRIs quicker in athletes because of this. Tendonitis. So the most common, being Achilles, peroneal, posterior tibial. A lot of this can, be due to the foot structure. Obviously we see, peroneal and posterior tibial a lot more commonly in certain foot structures. So just being aware of that. And, if they do have pain, over those areas, definitely looking at their foot structure and seeing if an insert or, shoe gear or something else could help them, as well as just treating the tendonitis. Posterior tibial tendon dysfunction, again, kind of goes along with the tendonitis. Usually you're going to, see that in kids with flat feet. So something just to remember. Medial tibial stress syndrome or shin splints. That's a big one. You'll see a lot of those, and it can be a very tough thing to differentiate between, more of the tendonitis, shin splints, and the stress fracture. There'll be some things I'll kind of talk about here in our case to go through, but that's something that you'll see a lot of people with flat feet. Will have this as well. Exertional compartment syndrome, that's a tough one. That's one that, it can be kind of a tough one to diagnose. A lot of times you'll rule out other leg, issues, shin splints, stress fractures, things like that. And then you kind of come, up with that. Everybody, athletes' presentations with this, usually are always funny. It's never like a, a constant thing or a repetitive thing. I mean, it's kind of more random. It's usually like just more of a cramping feeling. Typically, obviously worse. After their exercise or during the end of their exercise, then it goes away really quickly. And it can be tough to diagnose without the proper tools and devices. And if you don't have access to that or have that, then need to know where to send them. Metatarsalgia, and aromas. I mean, those can kind of go hand in hand. I mean, again, a lot to do with foot structures. Having a cavus foot, a higher arch. I always see a lot more, with these types of things. Plantar fasciitis, you're going to see that a ton in the general population, but then also, in the athletic population, you can certainly see that as well. Retrocalcaneal bursitis, again, can go along with sometimes, Hagelin's deformities or, posterior heel spurring, that type of thing. It's gonna be an inflammatory response. Not quite, as common as some of these others, but it's still out there. And sesamoiditis, that's a big one. You'll see that a lot of sesamoid pathology, with that you'll really see. And that's a great one to start off with, just, inserts, orthotics, offloading, that area, from a biomechanical standpoint. So we're at diagnosis. So how are you going to diagnose these? Clinical exam, just like anything else, is going to be your mainstay. But also, the stance, gait analysis, biomechanical exam, all these things are going to be very important. I think I've kind of already harped on this. I see a lot of people that come in with foot pain, but when I examine them, they don't actually have any pain, that I can elicit, no pain on palpation. And so those can kind of sometimes be tough, because the anatomy usually directs your diagnosis, and it's pretty easy when, they hurt right on the, navicular tuberosity or something. I mean, what's going on. But when they don't hurt, then it can be a little bit tougher to gauge. There's a lot of times where this is due to the foot structure and biomechanics, so, if they say they have arch pain, but they don't have any pain when we're pushing on them, but they have a very flat foot, obviously, that, okay, this is coming from, this flat foot structure. And like I said before, the flat foot structure in relation to the, tibial issues, very, very common. So these types of things, you'll see a lot, and you kind of need to know how to deal with them and, kind of rule out other things to make sure, hey, this is coming from just your foot structure, from your gait. Sometimes it can be as simple as good shoes, inserts, orthotics, and sometimes it can be like a gait analysis from a physical therapy lab or something. And then certainly, x-rays, it's going to be a mainstay with every patient, and then advanced imaging, MRIs, CTs, SPEC CTs. This, a lot of times you're not going to get right off the bat for normal patients. With athletes, sometimes you will. And depending on how much other treatment they've had or how much other, workup they've had from other clinicians or, athletic trainers or another sports medicine doc. I mean, you kind of will have to rely on these a little bit heavier. And again, like I said, a lot of times we'll have to, say, well, this isn't my normal thing. I usually don't get an MRI the first visit, but because, they're, what the coaches want or their demands. I mean, sometimes they kind of dictate, what you do, and you have to do things a little bit quicker. Everybody knows usually about MRIs and CTs. I don't know if you guys know about like SPEC CTs, yet, but that's kind of a combination of a regular CT and then like a nuclear medicine test, like a bone scan. Really, really sensitive for stress fractures. It's about the best you can get. I mean, there's a lot of studies out there that show just how the sensitivity of it. It's really, really great. If you can't figure something out, you've got an MRI. It's not whether it may show a stress reaction or it may light up, and they're not getting better, or you don't see anything and it just still seems like a stress fracture. Going right to a spec CT a lot of times is just, I mean, it's going to give you so much more information than just your bone scan or even CT scan. So that's a tip. I mean, I didn't. It's a newer thing. Didn't realize it, until I was out in practice. So here's what a spec CT looks like. You can see how this can light up. It's really cool. It's kind of like a hot spot. And so everything kind of normal is kind of a blue color. And then with the amount of contrast that they have, and that's the big thing, is just it does produce, it does, or take a lot more contrast. So if it's somebody that's a little older, unhealthy, you obviously don't want to do it. But, athletes that are healthy, can tolerate it, fine. But that's the reason, that it's this much more sensitive, is because of the amount of contrast. 92% sensitivity in diagnosing femoral neck stress fractures. That's just one study I found, but that shows you just how sensitive they are. I would venture to guess, it's similar, in the foot and ankle. Not as much literature out there, on it in the foot and ankle, but it should transfer. So treatment, for these injuries, just because they're an athlete, it is still okay to rest, and it's still okay to tell them that, hey, this is something that it's not going to get better until you stay off, but it's not going to get any better until you go into a boot or you stay out of play. And sometimes that can be a really tough conversation to have. To me, it always depends on, a huge thing is whether the athlete's in season or out of season. And that can dictate your treatment. I always, if somebody's in season, I always give them the option. Again, if it's say a stress reaction or something, where it's not going to debilitate. It's not like a navicular stress fracture where you're risking their future. I would give them the option of continuing to play and trying to get through the season versus stopping, sitting out, getting it better, and then playing. So that's a big thing. And the other thing is just asking an athlete, especially like a high school athlete that may be a multi sport athlete, what's the most important time of the year? Is it your school season? Is it your summer season? Is it your club season? And there's just so many different seasons these days, and they're playing certain sports all year round, that you really need to know, hey, just because it's the school season, this may not be the most important thing for them, and they may want to rest, be more inclined to rest now versus later on. So it's really trying to gauge that, talking out with the athlete and parent and everything. The boot, if they are in season, sometimes I'll allow them to, still continue to play, but be in the boot outside of play. So it's kind of a little negotiation tactic. You're still trying to rest them some, call it partial, mobilization. Really the goal of this is to not get anything worse, and I'll tell them that, hey, we're not probably going to fix it, but we're just trying to maintain until you can get to the season, and then you can, sit out and, and really treat this and fix this. Physical therapy, strengthening protocols, when an athlete has the athletic trainers at their disposal, it makes it so much easier. It's great. The relationship with them is wonderful. They can get things done and rehab so much quicker. So definitely take advantage of this. EPAT or shockwave, therapy, that's a huge thing. That's a big tool in my arsenal. Had it one in our office. I'm in an orthopedic office, and we use that. I use that, probably talk to at least, one patient about it every day. I've been doing that for about 5 years or so and had great outcomes. There's so much literature on it. If you haven't, looked at or talked about that or heard about that, it's a really, really neat kind of new, modality that we have, and it should be in any sports medicine physician should have it, in my opinion. I'll talk more about that a little bit later. So shoe gear, orthotics, bracing, taping, already kind of talked about, these things. But just, again, knowing, what types for different sports, what's important, for different sports, what's important for certain athletes. NSAIDs, steroid injections, NSAIDs, a lot quicker to doing. Topicals, even I'm always okay with giving an athlete, an anti-inflammatory for a couple of weeks as a prescription. Anything more than that, I'm a little bit wary. I don't like them being on something chronic that I give them. You worry about their stomach, their kidneys, things like that. So I like topicals a lot. They can put it on there when they need it. You're not gonna have the systemic effects. Steroid injections, is there a place for them in sports? And I mean, I think there is, but it's just being really careful with that. Knowing when, it's okay to do that, and what pathology you can do that with. I mean, plantar fasciitis, you still will do it. Certain joints, say somebody has an arthritic joint early on, or, a coalition, or, I mean, something, you can do that, but you definitely don't want to do that around tendons. It's just so easy to tear or rupture, things with steroid in an active athlete, just because, it's just because, the demand that they have. I mean, I'll do them still on these certain conditions, but, always tell them, take 10 days off, after. You can't play or do anything, active for at least that long, just to decrease the chance of tearing or rupturing. And then, can you let them continue to play? Kind of already talked about that, in season versus out of season, is an important thing. I think, some of these decisions, you necessarily can't make. Some of them, it is their body, it's their decision, it's their career. But all you can do is just give them, the benefits, the risks, of continuing on. And then, last resort, surgery. I mean, does surgery have a place, in athletes? Obviously, acute conditions that, you have to do surgery on to get them back out there. Yes. But we're talking more of, the chronic things. I mean, deformities, should you, do surgery, on an athlete that has a bad flat foot, or a cavus foot structure. I mean, I was taught, by sports medicine guys that, no matter how bad, a pro athlete's foot structure is, their biomechanics still got them to that elite level. So if you start messing with those biomechanics, they may not get back to that elite level. So anything from a biomechanical standpoint, I would really, warn against doing any surgery to, to change that until their career is over. So here's a kind of a good resource on, orthotics and sports, by Dr. Ward out of Florida. Really gets into, it's good detail on sports specifics, different types of sports, and pretty much the gauntlet of sports, and just kind of, good concept. So if you haven't heard of this book, this is a really nice resource. So Shockwave, EPAT. So this is like I said, a really nice tool. The longer we go with this, I mean, the more uses there are, more indications, more conditions. But the mainstays, obviously plantar fasciitis, Achilles tendonitis, stress fractures, non-unions, shin splints. That's kind of the foot and ankle arena. But any other tendonitis, really, peripheral neuropathy has been, started to have some good, indications, and some good data out there on it. And then, it's a larger scale, the rest of the body too. I mean, a lot of orthopedists are doing this on, knees, elbows, hips, shoulders. So it really does help, in the entire body. There's so many studies on this, so much literature out there on the effectiveness of this, that you just, type in, Shockwave or EPAT, into your search, and you can read on for days. I mean, it's just impressive with the amount of literature and good literature on this. The success rates are great, and it's a long-term thing. That's what I always kind of preach to, athletes, is that this isn't just a quick fix like a steroid injection or something. This is really going to fix the problem, and because the data points of this are like 1 year out, the endpoints of these studies are like 1 year. So if this type of stuff hasn't come back for a year, I mean, pretty good chance that it's not going to come back. The other good thing about this is, there's no downside to it. It's never going to hurt an athlete. It's not like a steroid injection where you risk tearing or rupturing or weakening. It's either going to help or it's not. So, and athletes can keep playing. They don't have to take the 10 days off like you do with steroid injection, that type of thing. So, really nice for, an athlete to try to get through a season sometimes, or, get things healed that may not, heal otherwise. So really good tool to have in your arsenal. So when to return to play, like I said earlier, kind of one of the bigger ones. the big thing is, as a sports medicine physician, you're not going to necessarily tell them when they can actually get back out in the field. You're going to tell them when they can start their functional rehab, when they can start working with athletic trainers, and then the athletic trainers are really the ones that, or physical therapists are the ones that'll put them through a functional rehab process and dictate, when they actually can go back to play. You're going to be the ones that just return them to start doing that. But I mean, there are certain, people or instances that don't have the resources. So if you do have to do this, which is, pretty rare for me, there are certain clinical maneuvers, that you want to have them do. One is a heel rise test. You're going to want them to go up on their toes, 1 foot, and without them falling all over the place or, really being weak. You want to see them repeat this a couple of times. This picture is of a single leg hop test. This is a really good one to do. If they can do this, like he did, and keep their core, strong and keep their core straight, with some good stability, then they're probably ready to go back to any sport at that point. Taping, bracing, footwear, to wear after an injury. Again, that's just injury specific. Just depends on, what the injury was, what's going on with them, but need to be, aware of, sometimes the transition out of a boot or a transition back into a sport does involve, plates, tape, bracing, inserts, all those things. And then the role of the athletic trainers, we already kind of talked about. Really their role is to get a person cleared for sport. Your role is to start the functional rehab process. Their role is to actually carry out the functional rehab process and, mimic certain sport activities, proprioceptive, techniques, things like that. And then again, it just depends on if they're in season versus out of season and how aggressive you're going to be with them. If they're in season, sometimes they're inclined to, just kind of, get back quicker, go a little bit quicker with everything. Whereas they're out of season, you want to make sure that, it's completely fixed and you're good to go before you start getting it back. So, kind of went through, that's kind of my talk on, sports medicine in general, just kind of go through a few cases and then, any questions you guys may have. So this is an 18-year-old Illinois State volleyball player with shin pain. Left was worse than right. A couple of weeks she had it. Also had arch pain. Left was worse than the right as well. Has been doing therapy modalities with the athletic trainers. Icing, ibuprofen, but no relief. So physical exam. The findings, pain to the posterior tibial shaft, left worse than right, no pain to the, the plantar arches bilateral. That's what I was kind of saying before. A lot of times you'll have somebody with no pain there, even though they say they have pain. So this is an example of that. And then, has severely increased arches with a neutral calcaneal stance position, bilateral, non-antalgic gait, didn't limp in here or anything. And then the x-rays I'll, show you here. So here are the initial x-rays. Standard, any leg pain, get tib fib views. You're going to have two, an AP and a lateral. Most of the time, you're not going to, see anything on these, at least originally. It'd be pretty rare to see, a stress fracture or any type of, reaction going on first time out. But you always want to, do this to rule out a tumor or something, crazy that's not going to be as common. So we also, just because she did have some arch pain, did get foot x-rays as well. And you can see, I don't know how clear these pictures are, but definitely has, kind of some supinatory changes with an increased calcaneal inclination angle and decreased talar declination angle. So definitely has that, kind of that cavus foot structure, like we talked about. And this was all the way back in 2018 too, when she first started having this pain. Here's the other side, similar deformity, as you can see. So differentials, shin splints, tibial stress fracture, fibular stress fracture too. I've have it where, the pain may be on the tibia and eventually, get an MRI and it actually shows, the fibula was it. It's not very common, but, it can kind of sometimes, both both long bones in the leg can, certainly have stress fractures. And then, like I said before, you kind of have to think about exertional compartment syndrome. It's got to be in the back of your mind, anytime you have a leg, leg pain patient come in. So initial treatment, we did treat this like posterior shin splints. And the reason for that really was more because the pain at that point was kind of in a broader area. And to me, usually shin splints, it's a big area. It's not just a pinpoint location, just one finger type location. Stress fracture, usually more localized like that. And then also having bilateral, most of the time you see shin splints being bilateral, versus a stress fracture being unilateral. So counseled on shoes, dispensed, some over-the-counter inserts, talked about, maybe custom orthotics in the future, continue physical therapy, modalities with the athletic trainers, avoid hard surfaces, and do leg strengthening, exercises, as well as getting back to play gradually after coming off of an off season. So all these things are just kind of your normal, shin splint, primary discussion. So next visits, she did do dry needling with a physical therapist. I didn't recommend this or really tell her to do this. This was just on her own. There's not really great literature on that, but she wanted to try that. So sure, fine, go ahead. Didn't get any improvement with that. So she elected to do shockwave. She was casted for custom orthotics as well, still being treated as shin splints at that point. And she was continuing to still play volleyball at this time. 3 weeks later, it was continuing to bother her, so she finally did go into a walking boot, on the left side, outside of volleyball. So this is what I was kind of talking about, where sometimes being in season, I'll allow them to continue to play, but they're in a walking boot, outside of play, and we call that a lot of times like the 22-hour rule, where they're practicing or playing for 2 hours of the day, and then the other 22 hours, they're in the boot. So she did this. 2 months later, the season finally was over. She made it through the season, continued pain. So we did order, an MRI at this time. And this did show a small cortical stress fracture to the medial distal tibial diaphysis with associated bone marrow edema. And this was just on the left leg because the left leg was worse. So you can see, how these things can kind of turn or how they can kind of fool you, with shin splints and stress fractures of the tibia. So here's the MRI again, maybe not the clearest pictures, but you got to get a sense. My arrow, you can see that. So you can see kind of the fracture line through here, on this axial view on the left side. And then on the left side, you can see kind of the bone marrow edema, here within the tibia. And this was in February. So we're talking, 4 months down the road, because really our primary goal, at first was just to get her through the season. And so she did get through the season. She accomplished her goal, but now we have, an actual stress fracture to deal with in the tibia. So next visits, she, after the MRI was back, she continued in the boot, but we also had her on crutches, non-weight bearing for 10 weeks, because a tibial stress fracture is what we call a high risk stress fracture. Meaning that if you don't immobilize them properly or get the proper treatment, they can easily go on to a non-union, take a lot longer to heal because of the, poor blood supply to this area. There are a few bones, in the foot and ankle like this. In the foot, it's really the fifth metatarsal, second metatarsal base, navicular, and then in the ankle or the leg, it's the medial malleolus, and then, the anterior and even posterior tibia. So she did this for 10 weeks, and then she progressed to weight bearing in a boot over another, 2 to 4 weeks or so. And that's usually what we'll do, if they're off, everything's kind of a transition, coming off of an injury. If they're non-weight bearing, then we'll start weight bearing them in a boot. And then after they're, been weight bearing in a boot without pain, doing well with that, then we'll start weight bearing, transitioning out of the boot and transition them into a shoe at that point. But everything's kind of a transition. So 2 months later, I think, this was still kind of in the summer. So 2 months later, she was, I think, getting back to school. And I want to say the season was probably starting at that point again. She felt like 95% improved. However, she still was, painful, just with pinpoint palpation, over that area. And to me, I mean, these stress fractures can be difficult because you can have somebody say, oh yeah, I'm 95% improved. But sometimes, that's an objective finding. I mean, subjective finding, they want to get back. So you can't sometimes trust an athlete based on that. I mean, in my opinion, the best, exam maneuver or best way to tell for sure is just to palpate. If they still have pain on exam, it's not completely healed. If they, if they don't, then you should be okay. So even a little bit of pain, you're still timid. So telling her that, she's still, elected to kind of gradually progress back to activity. I mean, it had been so long for her. She was off. This has been going on so long. She's been off of her, she was not weight bearing for 10 weeks and all these things. She was ready to at least, try to get back, which again, you can kind of tell them, you say, okay, you may be okay, but because you still have this pain, this, you could have a setback. This could, continue. So a month later, she had continued pain when trying to progress back. So another MRI was ordered, and this actually, the MRI, showed a resolution of a stress fracture of the stress fracture. Therefore, she continued to progress back to her volleyball activities. These were just new X-rays, during that time as well. Obviously, a lot of these visits, you'll get repeat X-rays because if you can see an actual stress fracture on the X-ray, then obviously what's going on, and then it's gotten to that severity level. But again, can't see anything on these either. So here was the MRI that had showed the resolution of the stress fracture. So especially on that axial, you remember where that fracture line was before. It's really not there anymore. So the MRI and very, very mild bone edema on the coronal. So that had kind of told us that okay, we should be okay. This looks like it's resolved or resolving, a lot, much improved than what it was before. So she continued to play, try to get through her season. However, continued pain. So she came in at this point with, continued pain, thinking that this was gone. I ordered a SPECT CT, and this showed bilateral increased uptake within the posteromedial tibial shafts, and this was significant for stress fractures. And this was bilateral, too. So before this, we thought that really, we're just treating the left side because this was the worst side. But with the nice thing about these SPECT CTs, it's like a bone scan where, you'll see the whole body, you'll see, bilateral extremities. So, this, anytime you have bilateral, that's something to think about too, getting that instead of like two different MRIs or two different CAT scan, or whatever you may do. So she played through the end of the season, but was in the boot, outside of play, again, 22-hour rule. So even though, we had seen these stress fractures, again, since she was in season, kind of discussed everything that I've already talked to you guys about with the in season versus out of season, talk. And again, she was frustrated. And deservedly so. And so she elected to try to, make it to the end of the season and then figure out what's going on after the season. You just have to tell them, that, hey, there's certainly a risk to this getting worse. Go to non-union, take, even more time than we've already, messed around with. So at that point, also discussed a bone stimulator versus a repeat, shockwave, treatment. And along the way, it also counseled her on vitamin D. I believe she was deficient. And so had, given her the mega dose of vitamin D before for those 6 weeks, like I discussed. But counseled her on this again, ordered new custom orthotics. Just pretty much throwing the kitchen sink at her, anything you can do because it's been going on so long. So here are her SPECT CTs. All three views, you'll get, sagittal, coronal, axial, and you can see these hot spots, and this is right, over that area, right in the kind of the posteromedial, aspect of the distal tibial shaft. So really cool, really, again, really sensitive. This picked up, both of them. And this, again, and you can see the dates here, this is over a year, after she originally came in with this. So, next visits, and COVID was kind of during this. Let's see. So this was kind of a couple months before COVID. Well, then COVID happened. So, sports got shut down. So she got a lot more downtime and she was back at home. I didn't see her, as much. But 11 months later, she thought that the pain had resolved. She thought this had all gotten better just, by the downtime, by being off of it, not competing in Division I volleyball. However, when she came back, the pain returned again. And this time, we ordered a bone stimulator, and she was using that on a daily basis. So fast forward to, October of last year. Again, new x-rays were taken, along the way. Again, nothing seen, on the original x-ray. And this is kind of a good, guidance point in terms of, you've seen, okay, a stress fracture on an MRI, you've seen it on SPECT CT, you still, even, over a year later, or I think actually 2 years, after the original pain, we still don't see anything, on the original x-ray. So original x-rays are just not very sensitive for stress fractures like these sometimes. So just both sides, showing similar thing. We don't see anything. This marker is just, sometimes my staff will put on there just to show where the pain's at, but nothing showed up there. So 4 months later, fast forward to March of this year, just a couple months ago, that's the last time I saw her. She, at that point, it wasn't really necessarily the same pain, but it was still kind of like, soreness, tenderness, more mild pain. It wasn't anything like that she's been dealing with, but because of her history, she just kind of wanted to know if this was gone. And so we ordered another SPECT CT, the most sensitivity there is, just to see, the difference and compare between the two scans. And this did show finally, complete resolution, of the stress fracture, or the stress fractures. So now, that mild pain, just being treated as opposed to, shin splints, she's still doing all those original things, working with athletic trainers, just continuing to kind of, work with this. And she continues to be able to play, her collegiate volleyball, which is her goal in the end. These types of things, a lot of times, you see these college athletes, just the amount of time that they're, competing in these sports, sometimes these injuries just don't truly get 100% better until they're done with college sports. And sometimes that's okay. They're tough. D1 athletes are tough. And as long as they know that, hey, this is maybe something I have to deal with, a lot of times then they can temper it and manage it okay. So here's those repeat, SPECT CTs from a couple months ago. And you can see the difference, those, they don't have the hot spots, like they did before. And you'll see, in the knee area, there are some, certain areas that do light up, but, she didn't have any pain there. Sometimes you'll see that. So you have to, kind of obviously clinically correlate just like you would with an MRI and everything. So here's just a classification, for medial tibial, stress syndrome, stress fractures based on MRI findings. So grade 1 through grade 4, it goes from anywhere from just, edema to bone marrow edema, visible on just T2 to visible on T1 and T2, and then actually a fracture line in grade 4. And the nice thing about this is it kind of guides your return to play. Now, I would tell you in a tibia, this is on the conservative side of things, because you saw what happened with her. If I told her return to play 9 to 10 weeks, she actually, I guess, did return to play. A little bit longer than that, but it actually was, a lot shorter than her pain. She was able to return to play a lot sooner than her pain resolved. And that's just, it's something where some of these bones that, that are high risk and just take forever to heal. And there's a lot of, there's literature out there that shows, these types of medial, posterior medial tibial stress fractures, they can take 12 to 18 months, really to resolve sometimes. This took every bit of that and even more. So it's just crazy, how long sometimes these take, but knowing that you're doing the right thing and there's not a surgery or anything that, can help this. So that was an interesting case. Hope you guys, enjoyed that. Definitely has been probably one of the longest, or longest injuries for an athlete that I've had to deal with. So second case is the last one. Is a 20-year-old female Illinois State gymnastics member who suffered an injury. So this is more of an acute thing, falling off the balance beam. 2 days before seeing her in practice, she hit her right foot on the beam during her fall, and she hyperextended her big toe in the process, but landed normally. So it was more of, she hyperextension type injury, on the beam. And it's really important to, to really go over the mechanism of injury, with the athlete, really be good about that. Really go into detail with that, because that'll help you a lot. That'll help direct, really what happened. And a lot of times they'll say, oh, it happened too quick. I don't know. But if they do, it can really help you. So her exam, most pain, was at the plantar first MDP joint, plantar sesamoid complex. Also some to the medial first MDP joint as well. There was bruising, there was swelling, present throughout, this area. So here are initial X-rays. You can see that these are non-weight bearing. That's because these were done at the student health services, and they don't do weight bearing X-rays. So it's definitely annoying to me. One good thing to do is just always take weight bearing X-rays unless they can't because of acute injury. She probably wouldn't have been able to right away very well. But anytime I see this, it's just, it's frustrating because you're not getting the full, biomechanical detail and workup like you would if they were weight bearing X-rays. But nothing acute, on these, no fractures, nothing that we see. So differentials, turf toe injury, sprain of the big toe joint, sesamoid fracture, sesamoid ligament tear, rupture, and that's something, you look for on the X-ray to see if there's any sesamoid, retraction. But again, that's very tough to see on a non-weight bearing X-ray. That's going to be more on a weight bearing X-ray. Osteochondral lesions, of the big toe joint, a contusion, of the joint, and then, again, compartment syndrome. There was a lot of swelling, so think about that. So our original treatment was to immobilize in a walking boot. We did also, spica tape the hallux in a plantar flex position. A lot of time, with the hyperextension, the injury is usually on the plantar side, and so you want to keep them in kind of a splinted position. It's really tough with the toe to be able to do that in a cast or a splint or something. So taping is a lot of times the best way of really holding them in a good position. Ice, elevate, rest. Obviously the normal things, after an acute injury. So her next visits, 3 weeks later, pain and range of motion did improve. So she started to try to transition from the boot, to her shoes, her athletic shoes, and had the hallux continued to be spica taped. I also gave her a turf toe plate. Turf toe plate's a really nice thing. A foot plate versus a turf toe plate, it's just kind of a metal carbon fiber shank that goes underneath the insole, of your shoe. And this can really be helpful to athletes. A lot of times that full foot plate, athletes don't tolerate, as well, because they don't feel like they can move their foot as well. They're really struggling, from that standpoint, to get as much motion as they know they should. So the foot plate or the turf toe plate can be nice because it's just their toe box. So the rest of their foot can still move. So things like this can really help. And I just counseled, that if this is a turf toe injury, this could linger through the rest of the season. This is just kind of a nagging, lingering type of an injury that just sometimes never doesn't go away completely until they, are able to rest this, more so in the off season. So 3 weeks later, pain continued. She wasn't able to progress, back to running or gymnastics activities like we wanted her to, like we were hoping she would. So we ordered MRI at that point, and that showed a capsular tear to the medial capsule of the first joint. So here's the X-ray. Here's the MRI, of that, and you can see, not a great picture, but you can see kind of the discontinuity there. That's kind of the capsular, ligament capsule there. That's incongruous and shows the tear. So 4 weeks later, her clinical exam, X-rays showed a worsening hallux valgus deformity. So she was developing kind of a traumatic bunion at this point. Hadn't improved in function, wasn't able to, get back to gymnastics or even running at that point. So she did elect for surgery, at that time. Basically I told her, like, I don't know how much longer this is going to take. This may, it's pretty unpredictable, with these, capsular tears, whether they will heal by themselves, but you're already developing this traumatic bunion, and who's to say, how severe this is going to get without doing anything to fix it. So she did opt for the surgery. Gave her some options. There definitely are multiple options usually for these types of things. discussed either an isolated primary repair of the capsular tear, an osteotomy, the distal metatarsal with a repair of the capsule, or a lapidus, with a primary repair of the capsular tear. And the reason she had multiple choices is because you can see these X-rays, our new weight-bearing X-rays that showed, there's rotation of the sesamoids. There's definitely a valgus component, to this bunion, as well as just the medial deviation, of the metatarsal head. So I felt like if I just repaired the ligament or the capsule, she was still going to have the bunion, and she was still going to have this increased, first IM angle to deal with, and she may have a recurrent bunion, later down the road. So I wanted to give her those options of trying to either do kind of a temporary fix to try to get her back to play as soon as possible, versus doing something that would, help her down the road and be a long-term solution. So that the metatarsal osteotomy, I gave her the option, but I really, that was kind of in the, on the fence, kind of in the middle. But my two options really were more of the lapidus versus just the primary repair. And she did elect for the lapidus. She was a pretty mature, girl for her age, and just saw that, hey, this is something that I want to correct, and I don't want to have any issues the rest of my life. And, so gymnastics is, so be it. So, I kind of gave her the expectations of, hey, our goal is to get this bunion fixed, to get your toe better, to get you in a better position and not have this recur. And if you get back to gymnastics, how quick you get back to gymnastics, that's kind of a bonus. And so she was very okay with that. And that's just where you have to set out those expectations, beforehand, and have that discussion, with your athletes. So the other thing is, you have to counsel her on all these things, but also, a lot of times you'll have talks with the parents, the coaches, the athletic trainers, and sometimes you can be repeating yourself, 2 or 3 times, giving the same talks to all these people. But it's very important to each one of them, to hear this stuff. So, like I said, she did elect for the lapidus, gave the expectations, that she may not be able to get back to competitive gymnastics, and keeping in mind her function was the most important thing. And one, good adage that I've always heard is, under promise and over deliver. And that should be taken to heart with athletes, especially. If you're giving them these out of control expectations and they don't get back, you're not going to have, athletes coming back to you. But if you give them, worse expectations, and then they meet those or exceed those, you're going to be the hero. You're going to really look like the good guy in this. So that's just kind of a tip. Never always give them, under exceed your expectations with what you're telling them. So here's after the surgery, turned out pretty well. You can see, able to fix the, that IM angle. Rotate the metatarsal out of valgus, get the sesamoids back underneath the metatarsal. So, turned out pretty well. This is a couple of months after the surgery. You can see the fusion is fusing pretty well as well. So, and end result from her, she did end up, progressing back to gymnastics. I think she had like an elbow injury and a couple of other injuries. So, she, I think, decided to kind of medically redshirt and end her playing career. But I talked to athletic trainers, and I don't think she would say that it was completely because of the foot. There's a lot of different issues going on. So I think, overall, a pretty good result, for her, and definitely met her expectations, and she was happy. So in conclusion, sports medicine is, very time consuming. Like I said, you really need to love what you're doing. Dealing with these athletes. You need to like sports. You really need to like these different sports, and and like dealing with them and helping them through these tough times. Think outside the box. Throw your entire toolbox at them. Your don't waste anything. Throw out your entire armamentarium at them. In order to get them back as soon as possible. It's really important to know each sport, and the demands of each sport. So, if you're an athlete yourself, you kind of understand, what it takes. If you're not, and you want to deal with, sports medicine, I would encourage you to, to read up on certain sports, kind of get educated on these, because, athletes really will trust you more if you really know what you're talking about, and kind of, talk the language and the lingo of, of certain, training activities, practices, drills. I mean, and sports and in general. Like I said before, always watch, patients stand, walk, understand the mechanism of injury. I mean, those are just good tips, in general. And counsel on injury prevention, get to know the athletic trainers, get to know the coaches, get to know the people you're going to interact with, before the season or before you get, before you start out, on the sports medicine journey. Vitamin D, orthotics, preseason, all those things, kind of preventatively. And then, be confident in your diagnoses, treatment plans. Don't get discouraged when athletes seek, second opinions, because, it is going to happen. It's just the nature of the beast with these things. You have to stand firm. You have to stand, pat on your values and your beliefs and your opinions. And then, lastly, like I said before, doing this work is rewarding. There's nothing like, getting an athlete through an injury, whether it be conservative rehab or surgery or what have you, and then seeing them back and, seeing their face light up when they, can get back. So references that I have, just a few here. So I think that's it. And appreciate everybody listening and take any questions, at this point.
Just real quick, I know there's another meeting at 7:30, so whoever needs to go, you guys can go ahead before I ask some questions.
Sorry for taking long.
No, you're fine. You're fine. So I do have a quick question. So when do you use, why not start on the bone stimulator versus the EPAT?
So bone stimulators, I mean, a lot of times these things will be insurance driven. So bone stimulators are expensive. Certain insurances will be okay with them. Certain ones won't. But it all depends on your diagnosis too. If you truly have like a fracture or a non-union, then you can always do that. But a lot of times, like, a stress injury per se, or, like before we knew that this was actually a stress fracture, insurance is not going to cover a bone stimulator for that. You actually have to have like a fracture code, or you have to have, some proof that there is a fracture or non-union. That a lot of times will dictate it. But yeah, I mean, because if you can, certainly you would do that.
Okay. And is that SPEC CT available usually everywhere?
I wouldn't say everywhere. Our hospital has one. Yeah, they're definitely expensive. Any university setting, nowadays, we'll have them. Any, educational facility or large hospital system, I would think would. More rural hospitals, those types of things, maybe not. But I mean, I live in, Evans, Central Illinois, Bloomington Normal, which is, a combined population of about, almost, 120,000 people. And we, our hospital has one. So, I think if you're in a big enough place, I mean, you certainly have access to one. I mean, I think they're getting more and more popular and more mainstream too. So by the time you guys are out, they may be, easier to find too.
Would you rather use a SPEC CT for like a stress fracture rather than a CT or MRI? Was that quicker?
It's not necessarily quicker. I mean, usually my go-to is typically still an MRI. But if I see something, on the MRI, and there's certain bones, again, that are high risk, like, so say a navicular stress fracture, those can be devastating. I mean, those can take, maybe not as long as a tibial stress fracture can, but they can take a long time and sometimes surgery. And so any time that I get an MRI first, that's kind of more of a broad thing. Like, it can tell me a lot more information, and then I can kind of narrow in on, okay, could this be a stress fracture? Is anything else? And then it's a stress reaction, or maybe even a stress fracture of a high risk bone, then I'll jump to a SPEC CT. Okay. If you do a SPEC CT first, right off the bat, you could be missing some soft tissue pathology sometimes, or, other things. So my kind of protocol is going, obviously an X-ray first, then an MRI. And then if either I see something that I'm concerned with, what could this be in terms of a stress fracture, or something that's just not getting better, then like her, then we'll jump to a SPEC CT and get a lot more information.
Okay. Cool. Does anyone else have any questions? right. I think that's it. Thank you so much, Dr.
Hey,
Paschold.
yeah, no problem. Yep. Enjoyed it.
Yeah.
Thanks for having me. Thanks
Yeah.
everybody.
Thank you. Have a good night.
Thanks, you too.